Okay, good morning, everyone. Can you hear me okay?
Yes.
All right. Let's get this party started. Okay, so a couple of reminders before we start. Try to keep your line muted unless you're speaking, but do not mute the IND line, please. That is our line here in the room. We'll do roll call voting per usual, and this meeting is being recorded. So Dr. Ott, would you like to call to order?
Sure. I will call this June 2025 meeting of the DUR board to order.
Did you have any remarks this morning?
I did not. Thank you.
All right, next is opening comments from OMPP.
Yes, I do have some comments here. My name is Namrita Yancey, and I'm the Pharmacy Operations Manager here at OMPP. I just wanted to welcome, or all of us wanted to welcome, our two new DUR board members. The first one is Dr. Brian Hart. Dr. Hart has been with Eskenazi Hospital in Indianapolis as an emergency psychiatrist since 2014. I would like to invite Dr. Hart to introduce himself to the board. Dr. Hart?
Hi, thank you. I'm very glad to be here. As she said, I am an emergency psychiatrist here at Eskenazi Health in Indianapolis. I have fulfilled a variety of roles over my time here. Perhaps most relevant to our business here is I've been a member of our hospital P&T committee since 2019 and a member of our psychiatric P&T subcommittee since 2017. But I'm thrilled to be here and a part of the group.
Thank you, Dr. Hart.
Welcome.
Next we have Elizabeth McCarty. We all know her as Beth from CareSource. Beth is a pharmacist and was with CareSource since 2017 as the Associate VP of Pharmacy for the Indiana Medicaid market. Dr. McCarty, would you like to introduce yourself to the board?
Sure. Thanks, Namrita. Hi, guys. Beth McCarty here. I just closed out 38 years, primarily in managed care pharmacy, and retired from CareSource at the end of May. So I'm excited to flip over and sit on the DUR board, and I'll be doing pharmacy consulting here and there in between traveling. So thanks.
Thank
Welcome
you.
back. Just can't quit.
Yes, my goal is to help drive quorum and make decisions.
Thank you for that.
We appreciate that and welcome.
What a goal. What a goal.
Any other comments? Nope. All right. Yes, welcome to vote. We're glad to have you here. Next up is the approval of the minutes from the May 16th meeting. Carol, did you want to get that started?
Yeah, sure. Does anybody have any comments about the minutes from the May meeting? And if not, can I have a motion to approve?
Move to approve, Dr. Marshall.
This is Beth, I second it. Or can I, because I wasn't there?
You were there, but not.
I'm not in the same capacity, sorry. I'll withdraw the second.
All right, so I'll do roll call voting. Dr. Ott?
Aye.
Dr. Hart?
Abstain.
Okay, Dr. Marshall?
Aye.
Dr. McCarty?
I have to abstain.
And Dr. Treadwell?
Aye.
Should be motion carries, right? All right, so next up is our call center stats. So I'll get that started. Maybe. All right, PA stats for May. So we had a total of 16,400 approved, a total of 5,547 denied. So that's about 75% approved and 25% denied. And we have this broken down into point of sale quick check and clinical call center. So for our new board members, I just wanted to kind of explain that. The point of sale quick check is the ability for us to review several items, various items at the point of sale period when the claim is being submitted to us. And if we see that criteria is met via that method, we can give an approved claim or a paid claim to the pharmacy. If not, it triggers a reject for reject 75 for prior authorization required, and then it can go to the manual call center for review. So point of sale quick check for May, we had 13,440 approved and 3,657 denied. Of those denied, we had about 25% go to the manual call center, where 79% were subsequently approved and 21% were denied. And then in the clinical call center, we had a 52% denial rate and a 48% approval rate. And here's our trending over the last several months. And we are fairly steady over the last few months. We did have a little dip this month, which is kind of expected. We kind of see that during the summer months, especially with kids being out of school, taking a break from stimulants, et cetera. And then our top 10 point of sale quick check PAs, a couple of things to note here. Well, the top 3 are the same. We have no changes in the top 3. I did want to note that GLP-1s used to be on this list, and they are now moved over completely manual review. So they're on the next list. And then the DPP-4 inhibitors that we're now checking for concurrent therapy with GLP-1s is being managed in the point of sale quick check. So that is going to be showing up on this list now. And then for our top 10 clinical call center, you can see GLP is our number 1, which isn't surprising. And then we also have Wegovy and Zepbound, which are making their way onto the list this month due to increased requests. Any questions about the call center stats? All right, we'll move on to opioid stats. So for May, we had a 1.41% increase in total opioid users and a 4.02% increase in new opioid utilizers. I just want to remind everybody to keep in mind that these are very small numbers. So even small changes in the numbers is going to shift the graphs and the percentages quite a bit. The utilizers under 18, we are about the same quantity, and we have the same about average day supply of 4.79 days per dispense. And then on the right-hand side, we show our total MME for the members, and then we have the number of utilizers, and then the last column is the PA exempt members. And again, for new board members, those are patients that have a diagnosis of cancer, sickle cell, palliative care, or other terminal illness that's associated with significant pain. So you can see our really high MME utilizers are almost exclusively exempt. And here's our trending for 90 and above. And then because, oh, no, we're not there yet, sorry. This is our breakout of current utilizers over 18, new utilizers, and current utilizers less than or equal to 18. Those have been fairly consistent over the last several months. And then here's our less than 90 MME. And the line graphs for the other MMEs broken out, we have to do the 90 separate because of the large volume. All right, any questions, concerns there? All right, great. Next is the retro DUR Dear Doctor letter proposal. Do we have, I sent that out last week with the deliverables last week. Does anybody have any questions, concerns, edits to the Dear Doctor letter? All right, if we're good to go, would you like to take a vote on that?
Is there a motion to approve the Dear Doctor letter?
This is
I
Beth.
move to approve.
I second, Beth.
All right, I'll do roll call voting. Dr. Ott,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
and Dr. Treadwell.
Aye.
All right, thank you very much. And then next up, we have the DUR board newsletter. Did anybody have any questions, comments, edits on the newsletter for us?
Sorry, I couldn't find my mic. I have a question. And it's not about what's in it. I think what's in it is great. Is this data, is there information that's going to go back to the Maternal Mortality Review Committee from this, or is this solely for Medicaid?
This is solely for Medicaid.
Okay.
All right, did anybody else have any questions or edits for us? Okay, would we like to proceed with the vote?
Is there a motion to approve?
This is Beth. I motion to approve.
Seconded.
See,
All
they're
right.
jumping in front of you, TR. You're slow on the uptake.
I know. I let these newbies get involved.
All right, I'll do roll call. Dr. Ott,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
and Dr. Treadwell.
Aye.
All right, thank you very much. And then up next, we have any updates from the MCEs? I don't think we do, right? Nope. All right. Okay, next is new drugs. So we do have a couple updates for you. We have a new drug, Benrafia, in the immunoglobulin A nephropathy agents. We propose criteria for those over 18 or 18 years of age and older with a diagnosis of proteinuria associated with IgAN confirmed by renal biopsy, and a documentation supporting a proteinuria of greater than or equal to 1 gram per day or a UPCR of greater than or equal to 1.5. And the member has to have had a trial failure of at least 90 days of therapy with an ACE inhibitor or ARB as monotherapy at maximally tolerated doses, and is at continued risk of rapid disease progression. Excuse me. And then one of the following member will continue their RAS inhibitor therapy while taking Benrafia, or there has been rationale submitted by the prescriber that they can't, as to why they can't continue their RAS inhibitor therapy. And then one of the following, they either have to have a trial failure of at least 90 days of Filspari, or rationale as to why they need Benrafia over Filspari. And they will not be using it concurrently with Filspari. And those that are of childbearing potential need to have a pregnancy test submitted within the past 30 days, and the quantity limit of 1 tablet per day. And then for our reauthorization criteria, we have a history of the requested agent for at least 90 within the past 120 days, confirmed by claims history or chart documentation. And then again, the questions about the RAS inhibitor, they need to be continuing therapy or give us rationale as to why they can't, and will not be using concurrently with Filspari. And again, quantity limit of 1 tablet per day. For our non-SUPDL agents, PA and STEP therapy, we would like to add criteria to Tezruli or Terazosin's solution. The member is unable to swallow capsule formulation supported by chart documentation. And then reauthorization criteria of history of the agent within the past 90 days. And again, an inability to swallow capsule formulation. For the transthyretin impacting agents, we have 2 new agents that we're adding to this on Onpattro. Our initial authorization criteria is diagnosis of polyneuropathy associated with hereditary ATTR. And member is 18 years of age or older, prescribed by or in consultation with a neurologist. And prescriber attests that member will not be using Onpattro with any other transthyretin silencer or stabilizers. And the quantity limit is 30 milligrams or 15 mils every 3 weeks. Reauthorization criteria is history of the requested agent within the past 90 days. And the prescriber attests that member will not be using, again, with any other transthyretin silencers or stabilizers. And then the same quantity limit. And then we have Wainua, which is initial authorization of diagnosis of polyneuropathy associated with hereditary ATTR. Member is 18 years of age or older, prescribed by or in consultation with a neurologist. The prescriber attests member will not be using concurrently with other transthyretin silencers or stabilizers. And then our quantity limit of 45 milligrams monthly or 0.8 mils. And then similar reauthorization criteria to the last one, which is history within the past 90 days. Again, not using concurrently with other transthyretin silencers or stabilizers, and the quantity limit. All right, and that's all I had for new drugs. Any questions, concerns? All right, can I get a vote?
Move to approve, Dr. Marshall.
Second, Pat.
All right, Dr. Rock,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
and Dr. Treadwell.
Aye.
Thank you very much. Next up, we have liaison with other boards. Do we have any liaison with other boards? No? Okay. And then we have any old business that would like to be discussed today. Okay, we'll move on to new business. We would like to make some updates to our Cushing syndrome agents. The Isturisa is an update in indication specific language to state the following: that the member has a diagnosis of endogenous hypercortisolemia in members with Cushing syndrome for whom surgery is not an option or has not been curative. Corlin, we would also like to update the indication specific language. We did send this out to you again last week with all the minute changes to the language. And then update the absolute contraindications to include prescriber attestation. The Lizodrin, update the requested dose quantity limit to 12 grams per day. And the Metapyrone, and add an absolute contraindication of adrenal cortical insufficiency. And then also update the requested dose quantity limit to 4.5 grams per day. Recorla, update the indication specific language and add some absolute contraindications to the PA. Signifor, update indication specific language, and then we removed the non-FDA approved indications that did not have insufficient compendia to support. Same for the Signifor LAR. For the non-SEPDL agents, PA and step therapy, we do have some updates to this criteria to the following. It has to have a diagnosis of chronic kidney disease and type 2 diabetes with estimated glomerular filtration rate, easy for me to say, of greater than or equal to 25 mils per minute, and persistent albuminuria with urinary albumin to creatinine ratio of greater than or equal to 30 milligrams per gram, with documentation obtained within the past 6 months. Member is 18 years of age or older. And then they have to have one of the following. It has to have utilized an ACE inhibitor or ARB therapy at maximally tolerated doses for 90 of the past 120 and will continue ACE or ARB therapy while they're using Kerendia. Or the prescriber has submitted rationale as to why they need the Kerendia and can't use the ACE or ARB. And then the same thing for SGLT2. So they have to have utilized SGLT2 for 90 of the past 120, which is confirmed by claims history or chart documentation, with plans to continue that therapy while they're on Kerendia, or the prescriber has provided information as to why they can't use SGLT2 therapy. For the reauthorization criteria, we wanted to update to member has a history of the requested agent within the past 90 days, and the member has utilized and will continue to utilize ACE or ARB therapy at maximally tolerated doses, or for some reason they can't use ACE or ARB, and then same for SGLT2, has been continuing to utilize while on Kerendia therapy, or has submitted medical justification as why they can't use it, why they have to use Kerendia as monotherapy and can't use SGLT2 inhibitor therapy. Okay, for the preferred brand drug list updates for implementation on 8/1/2025, we're adding the following to the brand preferred list. Just as a side note, we have decided to update our list a little bit and include authorized brand alternatives and authorized generics, along with the AB rated generics to this list. So we have kind of a bigger list to add this month. We have the Anoro Ellipta, the Orixia, Rio Ellipta, Comflera, Fycompa, Harvoni, Haromecta, Tasigna, Zytuvimet, and Zytuvio. And then removals from the preferred brand drug list would be the Airduo Respiplik. It's being discontinued. Okay, and then we do have one SEPDL update for leukocyte stimulants, Lupine. We want to maintain its current status as not preferred, but update the step therapy to require trial and failure of all the preferred short-acting agents, or that the member is going to be using Lupine in combination with an anti-neoplastic monoclonal antibody such as dinutuximab or naxitamab that requires concurrent use with Lupine. I think that might be it for new business so far. Do you want to take a vote now?
Sure.
Yeah.
Next is any
Yeah.
system. Okay.
Thank you.
Is there a motion to approve?
Motion
to
to
approve.
approve. I second it.
All right, Dr. Rock,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
and Dr. Treadwell.
Aye.
And then I think Anne is up for this portion. Just let me know when you want me to move forward.
So good morning. My name is Ann Kuhn. I'm one of the pharmacists with the Office of Medicaid Policy and Planning. And today I wanted to briefly touch on House Enrolled Act 1001 from the 2025 legislative session as it relates to mental health medication. So there's a lot rolled into HEA 1001, and I've tried to include all of the Indiana Code or IC updates related to mental health medication coverage and policy in this slide. The new legislation removes the prohibition previously in place that prevented preference on mental health drugs for the purposes of cost savings. So previously, all mental health medications had a preferred status. And while certain safety and utilization edits were permissible, preference and things like step therapy were not. So beginning July 1st, we will start the process of adding mental health drug classes to the SUPDL, soliciting for supplemental rebate bids, and then placing preference status on mental health drugs. The Mental Health Quality Advisory Committee will still act in an advisory role to the DUR board. Additionally, the new legislation establishes that one member from the MHQAC is to sit on the Therapeutics Committee. Those updates are outlined in yellow on the slide. The office is happy to announce that Dr. Ott has graciously volunteered for the dual position, or in Dr. Ott's case, triple position. So in accordance with IC 12-1535 20.5 OMPP asks board consider appointing Dr. Ott as the MHQAC representative on the Therapeutics Committee. Courtney?
All right, so I think because Dr. Ott is the chairperson, Dr. Treadwell, I'm going to have you obtain the motion and approval for this, if you guys are willing.
Yes. So I'll ask for a motion to approve.
Move to approve.
Move to second. This is Beth.
All right, and I'll do roll call voting. I think, Carol, you have to abstain, right? Okay. Dr. Hart?
Enthusiastically, aye.
Dr. Marshall?
Aye.
Dr. McCarty?
Aye.
Dr. Treadwell?
Aye.
Thank you. And thank you, Carol. Yeah.
Okay, and next
Sure.
up, we have public comment. Oh, sorry.
Oh, no, I just said, sure, thanks.
All right, next up, we have public comment. We do have two speakers who have requested to speak today. I have Paul Landis is up first.
Good morning.
Good morning. And we're ready whenever you are.
I am ready. So I'm here to speak about Xromi, the only FDA-approved liquid formulation of hydroxyurea for the treatment of sickle cell disease in pediatric patients. It is indicated, it's an antimetabolite indicated to reduce frequency of painful crises and reduce the need for blood transfusions in pediatric patients aged 6 months of age and older with sickle cell anemia with recurrent moderate to severe painful crisis. The clinical benefits: decrease in pain and hospitalizations, decrease in blood transfusions, decrease in acute chest syndrome, and decrease in death. Adverse events based on a safety study we conducted of patients under 18 years of age, adverse events greater than 5%, neutropenia was 13%, thrombocytopenia 9%, papular rash 6%. I'll summarize the product. It's individualized dosing for pediatric patients. It's a precise dose down to 10 milligrams. It is strawberry flavored, and it is also bioequivalent to the solid dosage forms. It is a combination product that is supplied as a bottle of 148 milliliters of solution. It also contains an adapter to facilitate uses of the syringes provided, which is a 10 milliliter, allowing for dosing up to 1 gram. and a 3 milliliter allowing for dosing down to 10 milligrams. I asked that the board consider removing or adding it to the formulary from non-preferred status to make it easier for providers to have access to the drug. As again, being the liquid formulation, we are seeing reports of denials coming out of the pediatric program in Indianapolis that the patient was denied because they were requested to use Droxia tablets. Again, it's the same active pharmaceutical ingredient, it's just a different formulation, capsules versus a liquid. We've also seen reports of another patient that was denied but then approved upon appeal because of the dosing adjustments required. So we do ask that the board consider quantity limits with this product as well, because as the child grows and they're titrating the drug, we can see the dose increase over time, and providers are reporting that they are having to do multiple prior auths for the same patient as they adjust the dose. That is my time. Thank you very much.
Thank you, Mr. Landis. Any questions from the board? No? All right. And then next up, we have Shirley Quatch.
Hi, can you hear me okay?
We can. Thank you.
Great. Well, good morning. I'm Shirley Quatch. I'm a value evidence lead with Novartis. Thank you for this opportunity to provide public comments on Vanrafia, a potent and selective ERA for the reduction of proteinuria in adults with IgA nephropathy who are at risk of rapid disease progression. That's defined as UPCR 1.5 gram per gram or greater based on the accelerated approval. Novartis respectfully requests that the step-through FILSPARI be removed in the Vanrafia policy. In the phase 3 study, patients receiving Vanrafia in combination with a RAS inhibitor received clinically meaningful and statistically significant proteinuria reduction compared to placebo, and results were seen as early as week 6 and sustained through week 36. Key differentiators for Vanrafia compared to other ERAs is that it is a single mechanism of action and therefore can be easily added on top of supportive care without requiring discontinuation or adjustment of supportive care. Vanrafia does have a box warning for embryo-fetal toxicity and a warnings and precautions for hepatotoxicity, but it does not have a REMS program for either of these like the other ERAs in this class. IgAN is a rare kidney disease. The incidence is only about 13 cases per million in the US and affects younger patients between 20 to 30. It's highly heterogeneous, and each person's disease journey and response to treatment is unique. And despite current standard of care, up to half of IgAN patients with persistent proteinuria progress to kidney failure within 10 to 20 years of diagnosis. These are young patients who will then require maintenance dialysis or kidney transplantation. And with that, Novartis respectfully requests that FILSPARI be removed as a step from the Vanrafia policy, and that it's available PA to label to allow patients and HCPs the options to choose the appropriate medication. Thank you for your time, and I'm happy to answer any questions.
Okay, any questions for Dr. Quatch? All right, thank you very much. John, did you want to do?
Is it like listed on? Okay. So I see that we have a representative from Lilly on the call, and I do not in any way want to put her on the spot, but Lilly had some questions about our ZEP-bound criteria, and we've been working through them. But I didn't know if she might want to speak to the committee, or certainly not required to do so, but I thought I'd give you the opportunity if you wanted to.
Yes, I'm on. This is Jennifer from Lilly. Do you guys have some specific questions I could address?
So there has been some questions about some specific aspects of the criteria with which Lilly has some questions, but again, if you're not familiar enough with that, we can hold off. I just didn't know if you were or not.
I mean, I have been in conversation with Optum, so I'm happy to answer questions if the board has questions that I'm happy to address specific areas that you guys would like me to.
So I'll put it this way. Are there any questions that you have for the board with regards to any aspects of the criteria?
I don't know that I have any questions. I know the, details of the contract are not public, so I've been going forward with Optum. We have put an offer to the state for coverage of Zepbound for specifically only obstructive sleep apnea. We know the state does not cover chronic weight management medication, so that is what the offer is for Zepbound for the indication specifically for obstructive sleep apnea. That help? I don't know if there are more details.
Okay, and again, if you're not prepared, that's fine. And again, I didn't mean to put you on the spot. I did not know if Lily had or wanted to address any specific aspects of the Zepbound criteria that were approved by the DUR board last month.
I just have seen them as Michael and I have been talking over the last couple of days. One of the things I know that, it's per label, like we've talked about. I think the label for Zepbound for obstructive sleep apnea includes patients that have a BMI over 30, have confirmed an AHI score, which is the score for diagnosis for OSA of 15 or greater. So on-label coverage, but not more restrictive than the on-label coverage. So I don't know what's appropriate to share about the offer. That's why I'm hesitating, because I know the offer I can't publicly share.
And no, certainly we don't want to discuss the proprietary aspects. It's really specifically about any concerns that Lily has with the actual PA criteria, not having to do with the supplemental rebate offer. So, and if you're not prepared, I didn't mean to put you on the spot. I just, I know that you've had questions to Optum, and I didn't know if you wanted to bring those to the board's attention, since they are the ones that approved those criteria last month.
Yeah, unfortunately, since I'm not legal from Lily, I can't approve or not approve criteria. It's just in my role as an account manager. I can answer questions about our conditions to rebate, but since I'm not an attorney, Lily does not allow me to approve or not approve PA criteria. I hope you can understand that. So I'm familiar, but I'm also, sense hesitancy in my response, only because my role is to answer questions about the condition to rebate, not to provide counsel. So that's where I'm kind of trying to dance the fine line of making sure you guys are informed and have the answers you need as a board, because obviously we want to do that. And whether that's from my side or from our medical side, we stand ready to answer any questions that you have. But I am not an attorney for Lily, so I cannot, counsel on specifics or approve specific criteria.
And Jennifer, thank you. I totally get that. So we will take this back and continue with our discussions. And if we need to bring that to the board next month, we'll do that. I know that this was like so hot that we've been even discussing it this morning. So, and I did not want to put you on the spot at all. I just didn't know what license you had with regards to being able to bring up the issues, but we will we'll bring that forward to the board next month. Thank you very much.
Yeah. And again, if there are specific questions, I'm happy to answer them and address them, but without having questions, it's hard for me to know exactly how to respond. Appreciate the time. Thank you so much.
You're welcome. And thank you.
All right, if there's nothing else, I think we are at adjournment.
My turn?
Yep.
Okay. So we'll go ahead and adjourn this June 2025 meeting of the DUR board. Thanks everybody for your participation and for being here and for voting me into another committee.
We know you love it.
Thanks, TR.
I'm on that committee.
Oh, God. Okay. Nobody reminded me about that.
We kept that on the QT.
Have a good weekend.
All right.
You too. Thank you.
Bye.
Bye.